All right, we are going to get started. I think people are in the waiting room trying to get in. So we'll make sure that they're all here for this grand round session. And I'd like to welcome you to the Cardiology Grand Rounds. I'm Partho Sengupta, and as the Chief of Division of the Cardiovascular Disease at Rutgers Robert Wood Johnson Medical School and University Hospital within the Rutgers-Barnabas Health, it's my distinct privilege to introduce an enhanced educational offering from the division. These educational offerings are voice for the division that aims in improving heart health through the creation and dissemination of knowledge within an environment that fosters collegiality, collaboration, respect, diversity of thoughts and action, and most importantly, innovation for transforming cardiovascular care and outcomes. We hope you will enjoy being part of this new journey. And before I go any further to the panel of guest speakers and esteemed panel that we have collected, I'd like to provide you some outline of the activities. We are providing this as a part of the Cardiology Grand Rounds, and CME credits are going to be available for this session for any cardiovascular professional that joins in. The videos are going to be also uploaded on the division websites, in the Grand Round websites, and there are YouTube videos that will be available for 12 hours, within which time frame you will be able to even get the CME credit. But most importantly, if you want to have the CME credited, please text now 12443 to this number 888-816-4893. I'm going to repeat 12443. Please text this code to the telephone number 888-816-4893. And this you can do within the 12 hours after the session. You can watch it on the YouTube and then claim the CME credit. For claiming this CME credit, it's important that it's a text as an SMS message and not an iMessage. And also you would need to have an active profile in the Cloud CME program for the Rutgers. If you do not have, you can go in and create an active profile, and then you will be able to activate the CME credits. As a new offering, we have also done something new for the physician colleagues. We are able to provide maintenance of certification points, which is extremely critical for licensure and credential activities. For this, you'll have to complete the step 1, answer a brief quiz at this link. Now, all of this link and all of these features will be available and circulated to you. But there is a room code that we are going to give it only now. And the room code is future01. Again, you can go in for 12 hours after the session you have watched it on the YouTube, which is a link provided on the division website. If you are able to go in and answer a brief quiz within 12 hours after completing the step 1, then you will be having maintenance of certification points. And for this maintenance of certification point, it can only be awarded if you text the attendance and the answers to the MOC question correctly. So please observe and listen to the content, because if there is an incorrect response, you will not be able to get the MOC credit. All questions to the panelists in this particular presentation, you can pose them as a question in the chat box, and I'd like to moderate that for you all. And the MOC questionnaires only starts after the panel discussion, so you cannot just go in and try to answer it, because if it becomes a wrong answer, then you'll not get the credit. So please be aware of some of these steps. But this is a direct link for your MOC credit after hearing this discussion and this presentation. And to introduce our panelists today, it's my distinct pleasure to invite Sanjeev Bhavnani, who's our first panelist and presenter. Sanjeev is a physician scientist in health innovation and practice transformation at Scripps Clinic and Research Foundation. He was a Qualcomm wireless health scholar with a focus to translate the advances in medical technologies. He has had interest in mHealth, big data, precision medicine, but he brings it directly to patient care. He has led a team of clinician researchers, engineers, and executed clinical trials not only in the US, but also outside US in Uganda, India, and Mexico. Has enrolled over 20,000 patients worldwide. He has worked with the digital health think tanks to develop the Connect legislation and the 21st Century Cures Act. As a cardiologist, he specializes in adult cardiology, heart failure and imaging, and critical care. And he has been recognized as a 40 under 40 life science innovator in San Diego. In 2017, Sanjeev led the ACC health policy statement on healthcare transformation in the era of digital health and big data. And because of this his wide ability to cover this topic, and because of a personal friendship that I've enjoyed over the years and the work we have done together, I thought he would be the perfect person to give us a start. So welcome, Sanjeev.
Thank you, Dr. Sengupta.
Glad to have you.
Pleasure to be with everybody.
And our second person in the panel to join us is Dr. Dipti Ichaporia. Dr. Ichaporia is an interventional cardiologist and the Eric and Sheila Sampson Endowed Chair in Cardiovascular Health, Director of Disease Management for Hoag Heart and Vascular Institute, and an associate professor at the University of California, Irvine. Most importantly, she serves currently as the 70th president of one of the most influential societies in cardiology, and that is the American College of Cardiology, which oversees over 54,000 members and professionals. Dr. Ichaporia has a long history in involvement with leadership with the college, and in addition to serving as the board of trustees and vice president and also secretary, she was also the chair of the ACC's board of governors, president of the ACC California chapter. She has served on the ACC Lifelong Learning Oversight Committee, Science and Quality Committee, Governance Committee, among others, and has helped to inform the ACC's innovation program efforts. And more importantly, she's such a great friend and such a great enthusiast. She's always been, we always converse long hours, and it's always wonderful to hear her enthusiasm, which is infectious. And we are so delighted that she has joined us on the panel despite her extremely busy schedule. Thank you, Dipti, for joining. Welcome.
Thank you so much, Partha. It's such a pleasure to be here. Anytime that I can spend time with you and Sanjeev, it's a good time.
And in addition to this, I also have another distinguished person, Rich Fletcher. Rich is a senior research scientist at MIT, directs the Mobile Technology Group within the MIT Mechanical Engineering Department, where he develops a variety of mobile sensors, analytic tools, and diagnostic algorithms to study health problems. Over the past 20 years, Rich has done extensive work in India. In fact, I met him on a flight while we were traveling together in India. And the collaboration has continued. He's so collaborative, and he has collaborated with organizations all across rural and urban, and he has ongoing research studies that are funded extensively by NIH, the Bill and the Melinda Gates Foundation, USAID, Vodafone, and the Tata Trust. In the US, Dr. Fletcher's research utilizes a variety of mobile technologies, wearable sensors, and Internet of Things. And he has worked in the area of wireless sensors and for the last 20 years with over 5 years in US Air Force, and has 20 years in MIT Media Lab, producing over 20 US patents and several spin-off companies. And it's just a great honor that he's so humble and so easy to approach, and he decided to agree to be on this panel at such a short notice. So thank you so much. So wonderful to have you, Rich, with us.
Thank you, Partha, for your kind words. Nice to be here.
And so to get the effort started now, I'm going to invite Sanjeev to give his presentation on the digital transformation of cardiology, the ACC perspective or the ACC roadmap?
Thank you, Partha. Thank you to everybody in attendance and to my fellow panelists. Let's get into it. These are my disclosures. So it helps to frame digital transformation. We've all heard these terms, especially over the past 2 years, but definitions matter, right? So I'll pose one now, right? That the tools, processes, and procedures that allow organizations to create, manipulate, and manage patients in an individualized approach using new data sets. But it's not just about technologies and devices. It has to move from device to data to knowledge, and aims to answer clinically meaningful questions, leading to improved efficiency and outcomes. So in digital transformation, right, on one hand, we have a real world on the other, right? For our audience, one of these pictures is a DMV in Los Angeles. The other one is an emergency room in Los Angeles. And I bet you're hard pressed to tell the difference between the two, right? We still live in an analog world, right? And so as we pose digital transformation, we really have to start asking questions on who are we designing for and what environment are we aiming to deploy. In years past, we've had low cost, low tech, low access to healthcare. This is known to everybody. Where are we currently? We have high cost, high tech, low access. Where do we need to go? That's digital care. Low cost, high tech, and high access, right? We've made strides towards this, and we'll speak about a few of these examples, but that's ultimately where we need to improve those efficiencies and those outcomes in digital transformation. So there's a lot of excitement in this field, right? Just from a funding perspective, right? I've often followed this because knowing the pulse of where activity is largely gives us an idea of where our interests also lie. And so in 2021, in just this year alone, by halfway through the year, we've already eclipsed more funding than was available in 2020. So the rate of rise here is really upward, maybe exponential, but we certainly haven't seen a plateau, right, in interest in investment in new digital technologies. So an example of this that many cardiologists and many in the audience will know is our 12-lead EKG, right? Designed actually a long time ago, right? But current devices that we use in our clinics, have about 300 parts to them. Within the last decade, we've seen that miniaturization and mobilization to one part, right? Smartphone EKG. Right? That one part can now do 6 leads. Right? And if we keep going, that one part can also do an EKG on your smartwatch, right? The ubiquity of technologies. But we've also moved towards 0-part monitoring, right? Looking at capillary blush through camera technologies, right? In order to capture heart rate and its rhythm. So that has led, overall, over the past 20 years, right? Particularly over the past 10, has led to a plethora of different digital devices. Smart rings for sleep monitoring, smartphone eye examinations to use in rural and developing countries to look at retinal diseases, smart necklaces, smart pills, genome sequencing. There's even smart skin, tattoo, conformable-like devices that can measure their biometrics, but also laboratory profiles, smart clothing, the watch, and the phone. So there's a lot of investment on one hand, there's a lot of devices on the other. So there's many promises, but where's the evidence? As clinicians and as researchers, we always have to ask this question. There's a lot of activity, but where are we with our evidence base? Because ultimately we have to design for evidence and we have to deploy evidence. So let's take a look at that, right? We have all experienced activity monitoring, right? So, and there is a premise that activity monitoring will lead to people becoming healthier. Well, if we look at randomized trials of wearable technologies combined with lifestyle interventions, in a young group of people between the ages of 18 and 35 with a BMI in the obese range, digital interventions actually led to less weight loss, right, than lifestyle modification alone. And so we should start thinking about that. Well, what about we take on one hand, healthy people, right, interested in becoming healthier. Now we go to a chronic disease like heart failure. Well, in the BEAT heart failure trial, which is the largest randomized trial of digital devices and remote monitoring, compared to conventional care without digital devices in an elderly high-risk group of people who've left the hospital for heart failure admission, it led to no difference in readmission rates at 1 month or 6 months with digital health. Okay, so we've talked about costs of care. Investigators from my institution looked at high healthcare utilizers, diabetics, hypertensives, people with atrial fibrillation, and gave them smartphone devices, a whole suite if necessary. Now, it wasn't tracked by physicians, it was patient generated and to use that information on their own. In high healthcare utilizers, found that there was no cost savings with digital health or a change in their utilization. Okay. Well, those were maybe younger people in an employed system. Well, the whole systems demonstrator, which is now going on 10 years since its results from the United Kingdom, looked at digital remote patient monitoring in high-risk elderly patients with diabetes, heart failure, or COPD, and compared to standard care, showed that digital health was associated with a higher cost of care and was not cost-effective in their healthcare environments. So we have a lot of questions here. What evidence we do have is largely neutral or negative. Okay? COVID has certainly been a catalyst for our digital transformation as we've all experienced telehealth over the past 18 months. And querying the EPIC databases on those institutions which participate in that electronic medical record, there was, of course, a shift due to the national shutdown, where there were more telehealth visitations than office visitations early on in the pandemic. But that shift changed 2 months later back to office-based visitations, supplemented by telehealth, but we see a plateau of telehealth at about 20% incidence across practitioners in the United States. So it is proof of we can transform. The degree to which we transform is one of the questions that we have to answer. So why is this? Right? So Dr. Sengupta and I embarked on this about 5 years ago, where we started looking at not just devices, we started looking at the spectrum of care, right? Those digital doctors, digital devices, and digital patients. And there are so many factors in that digital transformation. Clinical workflows, integration, is the data that is being acquired actionable? Regulation, reimbursement, the host of devices that you've seen, but also on the patient side. Patient-generated data is a term, but there's a lot of factors that go into it. The health literacy, the digital literacy of patients. How do they engage with technologies? Do they retain it? How do we do shared care, especially with elderly patients? So as we move from those definitions of device to insights to knowledge, as we look at the digital transformation, we will talk over a few of these categories. Innovation at the American College of Cardiology, digital health, right? Devices and our approaches for patient care. How do we digitize patient care? Can we look at new models of how we're using data? And then an endearing term of Care 180. Can we start turning things around, right? Can we change what we've been doing for the past 50, 80 years, right, into a new model of care? So in 2017, as Dr. Sengupta had alluded to, under the American College of Cardiology and its strategic initiatives, had put together a health policy statement of what is digital transformation across that spectrum of clinical care, patients, researchers, and administration. And so it brought together a multi-stakeholder engagement of people all across this continuum of healthcare, from academia, industry, investors, policy, the device makers themselves, to engage in a collaborative discussion, right, around digital transformation for cardiovascular care, the practices, and their patients. So as we started looking at this, right, we I shouldn't say quickly, we had to iterate, right, that it wasn't just about a technology. It was about a cluster of different innovations which all had overlap in those digital technologies, precision health, genetics, and then big data, right? Artificial intelligence, machine learning, data storage, really was all working together. And so we term this an innovation genome, right? And this graph taken, of course, from genetic type of studies. And so as we started looking at goals, right, in digital transformation and technology and data-driven healthcare, we asked some fundamental questions. Does the technology work? How do people interact with the technology? How does the technology improve a process? And then how do improvements in service delivery affect health of patients and health of populations? So we'll keep those questions in mind as we go over some examples, right, of technology used as part of digital patient care. Now, many of us now, in intra-COVID, have really experienced, people monitoring at home, that data being transferred via a cloud-based system to a care team with clinical decisions going back to the patient, right? So this closed loop system, right, of digital patient care. Let's take a few examples of that. At my facility, we have been doing remote patient monitoring for the past 5 years now. And if we look at hypertension, diabetes, and atrial fibrillation, which are, of course, prime disease conditions in which digital monitoring has a validated device or more than one, right, in order to participate in remote monitoring. And so what we had experienced over this time is integrating this information into our electronic medical record, because that closed loop, right, requires us to review that data and then create an actionable plan for that data. We look at an example of atrial fibrillation, right? Here in a 78-year-old gentleman who is using the smartphone EKG at home, right? As he's monitoring EKGs, he's capturing rapid atrial fibrillation. Now that permits the opportunity to modify his medications in order to reduce heart rates, perhaps improve symptoms. He converts into sinus rhythm about 1 week later. Now, 1 week subsequent to that, he goes back into atrial fibrillation and rapid AFib and continues to monitor. So as he's monitoring, we're also looking at his quality of life, right? There's a certain risk monitoring approach here in order to ensure that people are still safe at home, right? We continue to change medications virtually. No clinic encounters. Thus far, the patient did not require an emergency room visitation or a hospitalization. And so looking at where the efficacy of our medications through remote monitoring, we made an early referral for then rhythm monitoring strategies with cardioversion and atrial fibrillation ablation. And in this gentleman continued to maintain sinus rhythm. But an example of an elderly high-risk individual who's going in and out of paroxysmal atrial fibrillation, which could easily have resulted in clinical encounters. So we look at hypertension, and a couple of examples here on the spectrum of blood pressure monitoring. And this gentleman is 68-year-old, hypertensive and obese, right, is monitoring blood pressure in the range of 150 to 160. Treatments have been up titrated, and lifestyle modification has been delivered, but we're not making changes in blood pressure. And then something almost drastic happens, right? He starts intermittent fasting, and there is a reduction in an improvement in blood pressure. Now, as we're monitoring, I, as practitioner, didn't know what change he made because it certainly couldn't have been a medication, but he started and continued on intermittent fasting. So we're looking here about learning about patient behaviors. It's not just the blood pressure or the care delivery. There is a factor here where we can modify behaviors, or patients themselves can modify their behaviors. On the other side, a 76-year-old hypertensive, high-risk individual with ischemic heart disease, right, has uncontrolled hypertension, enrolls in our remote patient monitoring programs and sees a reduction in blood pressure as we would anticipate. Monitoring data enables the ability to treat that information, right? And then there's a change in blood pressure that goes up again. So we increase medications, right? Target pharmacotherapy in order to get to a blood pressure goal. So variability here allowed us to act on that variability in order to achieve a treatment target. Right? There's also information here, right, that we've learned over time, that these static one-time blood pressure measurements over a day, there's also patterns in this blood pressure, right, on a day-to-day or a week-to-week basis. Now, the questions are, how can we use this information? Does it inform pharmacodynamics of medications? Can we use such information to create individualized approaches to monitoring and to treatment? And are these precursors, or can we uncover patterns of disease in what we largely think is a common disease and treat across populations uniformly? So as we look to new devices, right, smartwatch configurations that capture central aortic blood pressure through radial artery tonometry. If you press down on your radial artery, you can feel the pulse, but you can also occlude it if you apply sufficient amount of pressure. So these devices created over the past 15 years can monitor 24-hour ambulatory blood pressure monitoring. And so we ask, where can this be important? Well, in that nocturnal pattern of hypertension, that nocturnal dipping, or that reverse dipping, that lack of dipping, which would confer a very high and an increased risk of stroke and myocardial infarction. And so the device itself is now enabling us the ability to look at risk monitoring at the individual level. Well, let's continue to continue with this hypothesis and line of thinking, right? We've talked about digital biometric monitoring, right? Looking at blood pressure, EKG, even glucose monitoring. These can be categorized into biometrics. Well, what about digital physiologic monitoring? So we're monitoring a number on one hand, and we're treating that number. Well, what about the underlying physiology? If we aim to change the trajectory of a disease, then ultimately we have to change and improve the underlying physiology. So there's now the emergence of exciting new nanosensors, passive resonance and piezoelectric phased array nanosensors that have been developed in several labs here at University of California, San Diego, where using conformable to almost tattoo-like devices that can measure underlying arterial waveforms, right, by using shifts in vascular distension from emitting sound, can now enable us to start monitoring continuous blood pressure. Well, similar devices have been used over the chest wall in Doppler-like configurations over a parasternal long axis to look at blood flow through the left ventricle and right ventricle, right? In order to now look at underlying substrate monitoring. Such devices are still very early on, but there's a promise in the progressive miniaturization in the ability to passively monitor physiologic information. Right? Here in my lab, over the past 3 years, we have been developing and validating a earbud-like device, right, that can measure infrasound. This is Richard's on the line. This originated at MIT, right, where the ability to capture very low frequency sound. As cardiologists, we specialize in high frequency ultrasound, right, in that 20,000 plus hertz range. The human audiome can hear between 20 to 500 hertz. But what about that infrasound range? Detecting sound at less than 20 hertz. I think we can largely agree that the body is making sounds. We just have not been able to capture all of them. Well, in an earbud-like device, right, in a miniaturized configuration, once occluded, well, the temporal artery runs very close to the eardrum. And what we're learning through new device formulations and form factors is that we're starting to capture information regarding underlying hemodynamics. And in one of our clinical trials, where the beat-to-beat capture of infrasound correlated very well to a regular sinus rhythm, but also an atrial arrhythmia, right? And studies are still underway in order to validate the tool, right, for cardiac rhythm monitoring. Well, as it's a sound principle, right, looking at underlying blood flow and hemodynamics, we have correlated such infrasound waveform information with invasive centrally derived aortic blood pressure, and to measure it according to cardiovascular time intervals, right? We can hear those with our cardiac auscultation, but can we miniaturize it in an infrasound-like device in order to capture continuous beat-to-beat blood pressure, but also the timing of aortic valve opening and closure? Does it have a representation to underlying cardiovascular hemodynamics and stroke work, or even aortic stenosis? And so as we've looked at examples and using this motivating example of hypertension, blood pressure as a static data point, I think we are all familiar with how we're using blood pressure in our current day. Well, if we push that forward to blood pressure as a time series data set, continuous waveform information, well, we can start analyzing such data and making correlations or assessing their correlations to the underlying physiology. So as a clinician, we've come to appreciate the various steps necessary to analyze time series data processing, the baseline drift in that information, and also noise factors. How do we filter it out? Well, can we extract features from these waveforms, right? Use wavelet transformation, use other types of methods in order to capture patterns in this waveform data to create features or variables, right, of blood pressure and hypertension. And then how do we use neural networking and other deep learning approaches in order to predict blood pressure using time series waveform information? So as we continue to look forward now in digital transformation, can we use clustering algorithms in our electronic medical record to look at hypertension across a spectrum of patient populations, to look at those clusters, right? Those clusters which identify higher and lower risk, smokers, diabetes, people with ischemic heart disease. Now, can we use such information by looking at populations, but creating clusters of almost individual patients, and now apply the right type of digital monitoring strategy, the right type of technology that can assess, mitigate, and improve this person's risk? And ultimately, can we get to target? So as we look at digital transformation, we have, of course, an abundance of clinical trial data in the cardiovascular community on treating blood pressure to goal in order to improve outcome rates related to hypertension, reduce the risk of strokes, myocardial infarction, and heart failure. So looking at a disease now through the lens of data science and informatics in clinical practice. So I'll leave you with one provocative example, right? And that is, how do we change this paradigm 180 degrees? So we're using new tools, right, for patient monitoring. Can such tools also be used at the point of care? So what's our conventional practice? Right? We all subscribe to this. Patients see physicians, order tests, wait for their results, right? What if we turned it around, right? What if we had our tests and our results up front and then presented that to the patient and the physician at the time of a clinic visitation in order to make clinical decisions? So we turn this model around. And so we've been lucky to work with Dr. Sengupta and Grace and Dr. Yamanala on creating such a model, right, in the CHOICE program in West Virginia about 3 years ago, where we started asking these questions of the yield of digital devices at the point of care, but can those devices and their information change that interaction with patients, and what's the impact of that interaction? So we created point-of-care digital clinics using, as in cardiology, EKG, ultrasound, vital signs, telehealth, and even a small cluster for point-of-care genetic testing. So upfront strategy. And when we look at this, there's many factors that go into our clinical workflows and throughput of patients in a healthcare system. So what would happen if they had upfront testing and engagement? Well, we might see improved patient satisfaction, enhanced provider workflows. Could we shorten that time to the initial diagnosis, atrial fibrillation, heart failure, uncontrolled hypertension? Can we have a more rapid throughput of patients? Can we reduce unnecessary testing? And how does this work within the continuum of referrals to specialists and also urgent care, ED, and hospitalizations? And what we found in preliminary information is, compared to standard care among 356 patients who were randomized in 10 hours, that an upfront strategy of digital health assessments was associated with a 62% greater freedom from cardiovascular outcomes, including emergency room visitations and hospitalizations. So small proof of concept type of idea through a randomized clinical trial on how can we start looking at our care engagement through a 180-degree lens. And so I'd like to leave you also, in considering digital transformation. We've talked a lot about technologies and we've talked about workflows and patients, but at its root, digital transformation is a human-centered transformation where we're upskilling clinical teams, medical students, physicians, researchers. And so at the American College of Cardiology, the central theme of that roadmap is a human-centered design and those principal components for how new innovations are implemented within the process of care. And it's a phased approach, right? And one that builds upon each step, from concept and product development to evidence generation, outcome measures, guidelines. What are our key performance measures? And then how do we adopt and engage in a scalable manner towards population health? And so we've covered a lot of information. I hope that you found it informative, and I look forward to our panel discussion. Thank you, Dr. Sengupta.
Thank you very much, Sanjeev. Again, a very comprehensive overview of so many things that you discussed. In fact, it's let me be pragmatic and more practical about what you presented, and perhaps we can start by asking some questions to Dr. Chapuria. Dipti, now I know that ACC wants to innovate. ACC wants to do a lot in digital transformation. What does it mean for a practicing cardiologist? And do you think this is real? How will it impact people? What should we be looking towards?
Yeah, I think that one of the messages that I have for this year is that, clinicians really need to embrace digital transformation. And let me define digital transformation. I know Sanjeev did that, but the way I look at it is that true digital transformation will make our lives better. And it will certainly make tasks easier. And if they make them more difficult, then it will help us in some other way. But they fundamentally change things for us. So to me, this is one of the compelling reasons that it actually will, it may be the very solution for clinician wellness. It may be the solution for providing health equity. So I think digital transformation is extremely important. And ACC sees digital transformation in really three buckets, right? So the innovation plan, the roadmap that Sanjeev talked about, it had three components. One was virtual care, the second was remote patient monitoring, and the third was AI-driven care. Now, we got a little taste of virtual care with the telehealth that we sort of saw the uptick of. Now, you could argue that telehealth is not virtual care, because really for at least cardiovascular specialists, we need some of that remote patient monitoring data and additional data to actually really get to virtual care, which is really what we want to do. And if you can get to virtual care, then you can create virtual therapeutics and all of the things that Dr. Bhavnani talked about, and maybe we could impact long-term care. So I think that we have, in the last 60 years, seen incredible movement in terms of the science of cardiovascular medicine, right? From the development, from understanding the pathophysiology of myocardial infarction, the developing VAD, statins. And now we've got technology, and we're just seeing a ton of technology coming out. So the problem here isn't that we don't have technology or we don't have science. The problem is that the system hasn't changed, right? Which is really what Sanjeev was getting at. So now the system is just dying to change. Why? And let me tell you, COVID has really brought to the forefront the reason that this needs to change. One is we've gotten in front of us the issue of health disparity and health inequity. So, and we have to address health equities, the social determinants of health and all that. I don't know that we could scale that issue without digital transformation, number one. Number two, we have consumerism. Now consumers have gotten used to talking to you in the car when they're driving for their visit. The consumers are asking for this. When they come in for palpitations, they say, can I get an Apple Watch? Can I put something on that? So a live port, all of these things. So consumers are driving some of this. The payers, right? The payers are saying, the cost of healthcare is just out of control. How can we really go towards value-based care? And in order to do value-based care, we really need to have innovation. And this is, one of the innovation So I think there are these drivers of the need for value-based care, the need to cut the cost, the need to provide care for health equity, clinician wellness, all of these drivers that we've seen during COVID driving this digital transformation. So instead of letting others decide what that's going to be, this is where we need to participate to say, this is what we need in order to drive digital transformation. And honestly, as I said, if you operate from the definition that it will fundamentally make our lives better, then it behooves all of us to embrace that and to say, okay, what does that mean? What is it that I need to do to make my life better in the clinic setting, in the hospital setting? And then can I work with my engineering partners to create solutions that may help me? So that was a long-winded answer, but hopefully I got to what you were asking for.
Yeah, so I think that's interesting. So Dipti, you're mentioning that the digital transformation and the tools and the science is somehow being taken very seriously with the ACC, and it's going to probably change the way we practice cardiology, and it's probably changing the way we're practicing cardiology. But perhaps, as you pointed out with the engineering question, I will. That will be a perfect segue to our friend Rich. Rich, life is very complicated, right? I mean, we want technology to work, but not every technology works everywhere. In fact, you've worked in different scenarios in rural India and other places where many technology don't work, and there are lots of physician and patient behaviors that interfere with the dissemination of technology. How have you thought about overcoming these challenges? I can tell you that we just went on Epic today, and it's not easy. It's very confusing. It's very chaotic. And when we're talking about very heavy terms of digital transformation, it's very scary to a lot of people. And a good community physician who's championed his clinic and patients really wants to get stuff done. And sometimes the technology doesn't connect that easily. It's more of, looks like it's going to be a loaded problem. How do we overcome that? And nobody else can answer this better than Rich, because you have worked in very difficult circumstances.
Yeah, well, thanks for giving me the hard question, Partho, but I will say that I agree with Deepti that a lot of the hope in a lot of these new technologies is to help reduce health disparities, but we now know, compared to like 20 years ago when we started creating a lot of these services, we know that there's a lot of disparities that exist in the technology itself, right? So just having internet access, there's a big disparity, socioeconomic disparity. And even more recently, in the topic of AI, it's become, people have observed and have revealed that AI itself is biased. And there are things that we need to do and processes we have to use to make AI itself more fair and more diverse, and so other groups can be represented in the models. So I think it's important that we have transparency in everything that we do, including the algorithms and the technology, and look at not only costs, but the way that these technologies are trained and the way that they're used. We have to look at transparency and disparity across all of these services and tools as well.
Partho, can I make a comment about
yes.
this? When I give my talk about digital transformation, I certainly address the issue of digital divide, which is sort of what Rich is getting at. And I think that is an issue. And that is why for example, when ACC advocated for, telehealth, they said it didn't have to be a video platform. It could be a telephone too, because there are rural areas that don't have good connectivity and all of that. And I do think long-term, we are going to have to address this. But when I was talking about some of the drivers out there for all of this, I recently listened to Cheryl Pegas, and she's the chief medical officer for Walmart. And she mentioned that Walmart is actually creating all these clinics. And guess what they're going to have? Number one, they're going to be providing some of this digital care, right? Because people want to go somewhere that they're comfortable with. But she was also saying that they're going to have booths there for these televisits to reach communities where they can't maybe afford internet or not have good connectivity. They only have these internet booths where they can go in and do their doctor visits. So I do think that there may be very many novel solutions that are coming forward for us to address these issues. But I think as we go forward and think about digital transformation, not only should we embrace it, we need to be thinking about these things. You know, how best to deliver the care. How do we do it equitably? How do we make sure the infrastructure? I mean, when I hear infrastructure bill, I want to know, are they going to improve connectivity in, you know, in our rural areas so that we can do all of these? That's what I think about infrastructure. That's the kind of infrastructure we need.
Yeah, no, I think that's a great point. So I wanted to ask Rich, what about the 5G and the connectivity? Is that going to be making it any different? We talk about Internet of Things. Is that going to be something making it more easier for people to access and in terms of technologies that are coming in?
Yeah, well, despite the hype that you might see, you know, by technology companies, 5G was designed for just a very specific use case in mind, where you have many people gathered in a small space. So things like a football stadium might be a great example, where you have a lot of people that need to connect to the internet in a very small space. But other than that use case, you know, 4G is good enough. 4G gives you, there's only so much bandwidth a human being can use at one time, right? So you know, 4G was a great leap forward from 3G, but 5G just fills in some special use cases like maybe schools or stadiums or large crowds. But 5G is a higher frequency, requires shorter range antennas. You need to put up more cell phone towers. So it's not the panacea, and it doesn't need to replace 4G. Anyway, that's the short answer.
Okay, so there are some couple of questions that are coming up. So my colleague, Dr. Karamelis, is asking, and it's very relevant. So we are very busy and we are very tired. Where do we get time to collect all this data, interpret, and how do we just take care of patients with all this additional information that Sanjeev, you're mentioning we need to collect, and the physiology, and how do we make sense of it? There's no time. How do a busy clinician do this?
Can I lead with that? It's a wonderful question. I struggle with it every day, right? As much like everybody in the audience. It starts with a question. Right? You know, how do you want to change one aspect of patient care? I think if every clinician or clinic starts asking that, we do have inundating workflows, right? We do have task baskets, right? We have a lot of things to do, right? But in that, what can we do differently, or what can you do differently? And it doesn't have to be very inundating. It is almost as inundating as one wants it to be, right? As I give an example, right? I spend 40% of my time doing telehealth. I constructed that in my schedule because if I did it in Siri, in sort of with my schedule, I wouldn't be able to do it, right? So I had to make that time investment, right, for what digital transformation looks like for my practice, right, and with remote monitoring. So what you'll find over time is that one idea will ultimately lead to another. And it's also participatory, right? These are patients and their caregivers, right, who are also participating in their care. So it's it's not onerous only on the physician's shoulders, right? That we harness that participatory model. And then there's nursing staff, which also becomes a key factor in these workflows. And so as one gets started, right, it becomes collaborative. And I think that's where, you know, the pebble gets into the pond, right? And then it creates a small wave, right? But it starts from asking that question, what is one aspect of this patient's care that I can change through digital transformation?
So almost you're mentioning that you need to start from scratch on redesigning how you want to see your patients and what you want to do with your time that you have. I mean, time is not going to increase. So within the finite amount of time, you need to restart, rethinking, start from the scratch. So that's what you're mentioning.
And so everyone's felt a pulse of this during COVID, right? With telehealth, as Dipti mentioned it, at that we've all had that feeling of digital transformation, Now the question is, what do we want to transform, right, through our individual clinics? And the answers will sometimes surprise people with what you can do.
Yeah, and I'm going to give a hard question, a relatively hard question that one of my colleagues is asking is, so Dipti, cost. So we on one side say that digital health is going to reduce the cost, should reduce the cost theoretically. But do you think by doing more data and more information, it could lead to more investigations? Number one. Number two is how do providers who are typically now so incentivized by doing procedures be incentivized by doing this kind of medicine? I mean, how do you see the field of cost and incentivization changing?
Well, okay, to go back, it kind of intersects a little bit with Sanjeev's question, which was the fact that how do you manage all this data? And this is where the AI part comes in. So hopefully there will be some analytics that will be utilized. So I'm also doing about 40% telehealth, and I will tell you that one of the things we're inundated by is all of this data from Apple Watches and LI cores and all of that. And honestly, we don't have time to look at all this data. What you really need, and what I would say to my engineering colleague, is that I need somebody that analyzes that data and gives me a report card that sort of synthesizes that. And we've seen that, right? The BioTels, all of some of the monitoring devices does that, so that we can get down to the nitty gritty details. So what you want is a report card that synthesizes that information. And then you get enough of those report cards and you synthesize enough of that. Guess what? That helps you create then another pathway to say, this leads, so you can do therapeutic and decisions based on the patterns that you're seeing that lead you to something else. So hopefully you can take a large amount of information, learn something, and then those patterns will help you to narrow down your trajectory of what you're trying to investigate. So that's what's going to drive the cost down. In terms of being paid, we may be able to scale volume in some ways because of the way that we do it digitally. So that may be able to make up for that. And maybe some of the payment, if we truly go towards value-based care, which is really what they're driving towards, they have not wanted to pay us for fee-for-service for a long time. And if we truly go towards value-based, then hopefully these data, the analytics and all of this is going to improve outcomes. And if we improve our outcomes, then we get paid, we'll get paid more. So hopefully we can set off whatever we lose in terms of the number, the fee for service, and that by the fact that we can use all of this and improve our care and the outcomes. Because now we're going to get information about patients that we never knew. I mean, hopefully part of remote monitoring is that I'm going to know things about you, Partho, when you're well. And that'll help me to know when you're not well. But see, now all we really do is provide sick care. We really don't provide health care. Health care is when I know when you are healthy, so that I know when you're not healthy. But all I do is see you when you're not healthy, and I have to make heads and tails out of that.
Yes, so I think I'm going to tell you that the dialogue has really made the audience very excited. I'm seeing a plethora of questions popping up, so we might have to go through them fairly quickly. So Dipti, a question another for you. Now that we know that there's a value to this, how do we initiate the discussion with the administrators and the hospital? Is ACC doing something that we can show and then take that to our hospital and administration? Because that's how usually typically our programs are defined. And what do we do about it?
Well, I think first of all, have a conversation about value-based care and how the models are changing. And honestly, money talks, right? So that the fact that we're talking about money will get their attention, number one. But it would be hard for me to believe that there is an administrator out there right now that does not want to discuss digital care, given what we just went through with COVID and how difficult it was to have people in the hospital. If you can provide care and still get paid and nobody's in the hospital, they're gonna be happy about that. So absolutely, they're going to embrace that conversation.
Great. Rich, I want to just come back to you. I think you do such wonderful work abroad in India, and you've done some very cost-effective work there. So can you give a quick example, one or two of things which are very cost-effective, but made some big impact?
Yeah, I think, making hardware is costs a lot of money and takes a lot of effort. So the more that you could do with phones, and something that's been impressive for me personally over the past 20 years is how important even questionnaires are. So we still use quite a few questionnaires, and we do a lot of creative things with the mobile phone. Like, for example, you could get your pulse just with a phone. You could also get your pulse just holding your phone in your hand. You could get the accelerometer, seismocardiogram. So the smartphones are very powerful and have a lot of sensors built in. So I think the community health workers are now starting to use just the phones by themselves. There's a lot of things you can do just with the phone without having to distribute and sell hardware.
Very good. So that's important. So we're going to focus on more use of cell phone and technologies related to that. That's going to be, that's what your direction you're providing is. Sanjeev, there was a quick question. Can you pick up an S4 from the earbuds? Everybody's excited about the earbuds you spoke about. Nobody wants to auscultate. We want to go for something quick. Yeah.
Talk about a dying skill, auscultation, and to a cardiology community, of course. We're working on it. Right, and we'll let you know when it comes out.
Okay. What is, and this may be again, what is the role of patient participation, acceptance, and compliance? Do you see basically a patient fatigue when they don't want to respond to certain types of interventions? Have you encountered anything like that? Maybe Sanjeev, you do this more frequently. So can I ask you about this?
Great question. Meet people where they are. Right. Understand the expectations on all sides. Right. And largely look to teach and educate, right? Patients, their caregivers, but also your clinical teams. So once there's mutual acceptance and a mutual agreement almost on what monitoring aims to achieve for this given patient, then it'll largely be more successful. But be cognizant of it. So very good questions. Understand the pulse of your patient.
Yeah, and Dr. Ranita Sharma is asking, I think she probably is referencing to something like a Hawthorne effect. So if a patient is being watched by the provider through the cell phone, let's say if the data is getting collected, do you think it leads to a better compliance if they know that somebody is continuously watching? Do we know about anything related to that? Maybe, Rich, you want to take a stab at it?
Well, I would say you could give people some pretend wearable sensors, and if they think they're being monitored and that improves their behavior, then that's great. What I'm saying, the Hawthorne effect could be used as a motivator.
Yeah.
So, but yes, the technology does influence behavior, but doctors can use it in a creative way to improve our behavior all around.
Yeah, it makes sense, right? If you're hypertension and diabetes and simple risk factors monitoring, and somebody's going to be watching you, maybe we need to go back and ensure that people are compliant to the regimens that we are prescribing. And we are probably looking into downstream treating the sick patients. That's what Dipti is referring to. We are treating sickness, not monitoring the healthcare of the patient. Now, there's so much of data coming in. Who regulates them? Ethics, legal point of view, who's responsible? These are very big challenges, right? Yes, Rich.
Our group just did a paper on AI fairness and bias recently, and one thing we were advocating for is we feel that algorithms should be regulated, at least apply for in medical applications. Algorithms should have some sort of regulation similar to the way we regulate pharmaceuticals. So there should be transparency. You should know what data you use for training and what are the certified and approved uses for that algorithm. So you could have off-label and on-label uses of an algorithm, and it's important for people to know what are those uses so that people don't use the algorithm in the wrong way for the wrong purpose.
Yes. Good point. So we'll, by the way, the primary reason we started off with this topic for our rounds is because we are trying to motivate physicians to participate in this this evolution, and we are going to try to create an innovation hub where people like you all can directly come and provide insights and engage with the community provider on what they can do as we start evaluating some of these devices and using them. And in fact, FDA is providing so many approvals to devices every month. And I mean, I'm hearing about a lot of digital devices coming into the market. Before someone else tells us how to use them, I think it's important that we partake in evolution and decide how we're going to use it, and tell our institutions and administrators that we find this is more applicable to our scenarios, because every scenario is different in different part of even the United States. With that note, thank you very much to this very esteemed panel, very, very exciting conversation. I think people are still continuing to put their comments, but what I'm going to do is the hour is up, and we're going to bring back the request on finding out how to get the CME and MOC points. So again, this is recorded and is going to be stored on the division website. You can go there and watch it. You can tell your friends and colleagues if they have not watched it, they can go and take a look at it within 12 hours. And if you want to get a CME credit for this, you text 12443 at this phone number, 888-816-4893. Text us an SMS message. And if you are a physician, then you want to do this step and also try to take the MOC point by taking a brief quiz. And there is a question that Sanjeev has posed to all of you. Hopefully you can answer it and answer it correctly. The room code is future01. Remember, again, we'll have to come back. We'll have to do this within 12 hours after this is relayed. But this will allow you to have the MOC and the MOC point will directly go into your ABIM. Important that you also have registered on the website at the Rutgers Cloud CME if you want to get your MOC points as well. Thank you very much. With that note, we conclude the first grand rounds. And this has been exciting times, and we look forward to having the speakers once again, hopefully in the near future, locally in person. Thank you very much.
Thank you, everybody.
Thank you.
Thank you.
Thank you.